Good morning, everyone. Well, it looks like the count has slowed down a little bit, so we'll go ahead and get started. Thank you all so much for joining us this morning for this first Rhode Island webinar Shot of Knowledge 2025 Respiratory Season Update. I'm Dr. Michelle Fiscus, and I will be leading us through the webinar today. If you want to go to the next slide, please. So just a few housekeeping items. We're going to go through the agenda, housekeeping, just a few things. And then I will present a national overview of respiratory virus season. Then we'll switch over and talk about some Rhode Island specific information. We'll review the upcoming recommendations and changes to recommendations for respiratory season vaccines and talk a little bit about messaging strategies and provide some resources to hopefully help you with that. Next, please. So our learning objectives are to help you all understand what's going on with respiratory virus season, specifically around COVID, flu, and RSV, epidemiology and vaccination and recommendations, and to use and understand evidence-based strategies to help people get vaccinated and use patient-centered messaging to help improve vaccine confidence. Next, please. So this is a recorded webinar. It will be housed on the Rhode Island Department of Health's website. It will also be sent out in a link to everyone who is registered for the webinar. So you will get copies of the slides and of the webinar recording. You should know that the views of the presenters here reflect our own views and not necessarily those of any other organization. But they do reflect those of our own organizations, the Rhode Island Department of Health and the Association of Immunization Managers. If you'd like to ask a question, we encourage you to use the Q&A box that you'll see at the bottom of your screen. The chat has been disabled for this particular webinar, and we'll answer as many of those questions as we can get in. And if you wouldn't mind just taking a moment at the end of the webinar to answer a couple of brief survey questions so that we understand how best to get information to you in the way that you need it. Next, please. So let me introduce myself. I'm Dr. Michelle Fiscus. I'm a board-certified pediatrician. I spent about 20 years in private practice in Tennessee before moving to state public health and ran the COVID-19 vaccination response for the state of Tennessee. I now live in Maryland, and for the last 3 years, I have been the chief medical officer at the Association of Immunization Managers, which is a national nonprofit that supports the 66 federally funded immunization programs across the United States, several major cities and U.S. territories and freely associated states. I am joined by Dr. Tosin Ojugbele, and she is the medical director of the Division of Community Health and Equity and Environmental Health at the Rhode Island Department of Health. She is an assistant professor of pediatrics and practices primary care in the community. And prior to joining the Rhode Island Department of Health, she served as the director of the Fostering Health Clinic at Hasbro Children's Hospital. Dr. Ojugbele completed her MD and MPH in community health science at SUNY Downstate, pediatric residency at Northwell Health Cohen Children's Hospital, as well as a postdoctoral fellowship in primary care and research at Dartmouth Hitchcock. So we will look forward to hearing from her in just a few minutes. Next slide, please. So let's talk about the national landscape of respiratory virus season. So this is looking at last year's data, the 24-25 influenza season, and these are CDC data. And you can see that this season began in September of last year, September 30th, which was a little bit early. If you want to click that first click there, perfect. And then it peaked January 27th of last year. And then mostly what we saw was H1N1 virus, which is typical of most flu seasons since the H1N1 pandemic. And we saw some H3 virus and some Victoria B virus. You can click through those, please. Just note that, once again, we have not seen the B strain Yamagata. And if you'll recall last year, that B strain was removed from the flu vaccines, making those trivalent vaccines where they had been quadrivalent vaccines since shortly after the 2009 pandemic. Next slide, please. when we look at how these epi curves have looked year over year, last year you can see we had quite a high peak in 2024, 2025. The peak to the far left is the year immediately following the pandemic. Go ahead, next. And then the 2023, 2024 peak is just to the left of last year's peak. You can see that when you look at this graph, the peaks have moved later in the season since the pandemic. So there has been some resetting of the trajectory of influenza since the pandemic. And that purple kind of line, that's the 2017, 2018 line. And that we had used as the, 2017, 18 was a horrible, horrible flu year, as we looked at years, because no other year had really rivaled 2024, or I'm sorry, 2017, 18, except right after the pandemic. But you can see that this past year, we actually surpassed that. So it was quite a severe year. Also, to the chart on the right, you see that the coverage rates of influenza vaccination for different age demographics have all decreased from 2023 to 2024, with the exception of vaccinating in pregnant people, and that increased just slightly last year. But every other age demographic saw a reduction in the vaccination coverage rates. Next, please. I do like to go and look at the Southern Hemisphere. We can't always take the Southern Hemisphere data and apply it to what's going to happen here. But if you'll recall, in the Southern Hemisphere, their flu season is actually in the summertime. So Australia just finished up their 2025 influenza season. And you can see that they had a lower peak than in some previous years, but this very broad kind of almost plateau before the decline, which is a little interesting. And you can see there too how the peaks have continued to march a little bit later into the season since we've gotten past the bulk of the pandemic. That 2022 line, that dotted line, is the one that is furthest to the left. And again, that's the triple-demic year that we all talked about. A severe season for RSV, flu, and COVID, but then a very early influenza season in the Southern Hemisphere as it was in the Northern Hemisphere. Next, please. And then you can see last year, the peak of the season was higher than this peak for this year. But because of how prolonged the season was, there were actually more cases in 2025 than in 2024. Next slide, please. You can see that here where this is the number of cases, the cumulative number of cases over the season in 2025 really eclipsed the 2024 dotted line, which is that black line just below it. Next, please. So we see these graphics frequently from CDC that show these very large ranges of counts for illness, hospitalization, medical visits, and deaths. And this is the last flu season, and then the preliminary 2024-2025 COVID burden estimates. I always find these a little bit difficult to explain just because the ranges are so broad. And so if you go to the next slide, I actually asked ChatGPT for a little bit of help and asked it to actually compare these ranges that have been shown between flu and COVID. And at the bottom of the slide is the prompt that I used in ChatGPT. The little black lines that look like candle wicks are the ranges that were reported. And this is a logarithmic scale, just so that we could fit the deaths and the hospitalizations on here as well. But you can see that for illnesses, for medical visits, and even for hospitalizations, flu clearly has been the major player over COVID. But when we get to deaths, that range for flu actually spans across the range that we saw for COVID. And so when it comes to deaths, there is significant concern about the amount of deaths that we're still seeing from COVID-19, and it really rivals what we see from deaths from influenza. Next, please. As you know, we've had a government shutdown for about a month now, so CDC has not been reporting as it usually does its surveillance for COVID-19, flu, and RSV. We do know from some emails that we've received that nationally the COVID numbers have continued to go down, which is typically what we see this time of year. And then we often begin to see a bit of a spike just after Thanksgiving because of all of the gathering and travel that happens. Next slide, please. Next post, thank you. And then this was the last post about RSV, COVID season. And you can see that downward trajectory at the end of September. Next, please. For RSV, again, just like we saw with flu, the peaks of these seasons have continued to march later since the pandemic. So here you're seeing the 2022, 2023, and 2024 seasons. We have worked very hard to try to prevent RSV in newborns by enrolling birthing hospitals to provide RSV monoclonal antibody to newborns that are born during RSV season or who are entering their second RSV season and are high risk for significant RSV disease. So about 36% of birthing hospitals across the country are now enrolled and giving that monoclonal antibody birth dose. That gives us a long way to go still. And unfortunately, this is very geographic. So there are some states that have very little in the way of hospital participation, and some states like Rhode Island that have 100% hospital participation. But it was a significant increase over last year's participation in the program. Next, please. So nirsevimab ordering by birthing hospitals increased by 118% between the first and second seasons, which is wonderful. We should see continued increase in those numbers this year. 39 of the 64 immunization jurisdictions achieved more than 30% enrollment in their birthing hospitals. Next, please. And 6 jurisdictions, including Rhode Island, have 100% of their hospitals enrolled in giving birth dose RSV immunoglobulin to babies to protect them. Next, please. So that RSV monoclonal antibody and vaccinating pregnant people has had a tremendous impact on reducing morbidity and mortality among infants for RSV. If you'll click, please. So what they have seen is a 28 to 43% reduction in hospitalizations among 0 to 7-month-olds compared to pre-pandemic rates. And we've not only seen this in the United States, but we've seen even greater numbers in other countries, for example, Spain and France, that have a national health system and therefore can get this product into all of their hospitals and have it covered. They have seen reductions in hospitalizations and morbidity and mortality in the 90 percentiles because of these products. So they are tremendous products. And just as a pediatrician, the ability to prevent RSV in a young infant is just astounding. And we need to be doing everything we can to get these babies protected. Next, please. So I'm going to turn it over to Dr. Ojugbele, who's going to run you through some Rhode Island specific data, and then I'll be back in a minute.
Thank you, Dr. Fiscus. So to talk a little bit more about the Rhode Island landscape, and I'll go to the next slide. So this graph is data from Brown University Health. It's pathogen testing. And what it shows here is our respiratory pathogen panel, or RPPs, as well as rapid molecular assays. And these data include specimens that were collected from inpatient ER visits, as well as outpatient visits. So we can see that this past season, our peak influenza, which is seen on that green dotted line, was in February, and our peak RSV, which is represented by that orange line, was in January. We also had higher COVID positive tests around that same January 2025 time with COVID that you can see on that dark blue line. And it's interesting to see here visually that we also had that blip of COVID in the summer as well. We had that in 24 and 25, and that's consistent nationally that we see those summer blips of COVID positive testing. Next slide. So this a little bit more easily depicts our current respiratory virus activity. It shows again that Rhode Island experienced a summer wave of COVID-19, as demonstrated here by the percent of emergency department visits with diagnosed COVID, flu, and or RSV. And that blue line specifically, again, is the COVID-19 activity. So that peaked in September of 2025. And since then, our COVID-19 activity has been declining. Currently, there is very little influenza and RSV at this time, and those rates have remained stable. And next slide. So this graphic is reflective of the COVID and flu hospital admissions, and we saw an increase in the number of COVID-19 hospital admissions over the summer at that same time that we saw that increased activity. And next slide. So this graphic from our last influenza season shows us the percent of emergency departments with diagnosed flu, and this is broken down by age. So it shows us that children 5 to 17 years had the highest percent, and that's represented by that light blue line that you see at the top. And this is followed by children age 0 to 4 months, which is that dark blue line next to it. And then the next highest is older adults 65 plus, which is on that dark green dotted line. And this is consistent with what we see in terms of the highest risk for more severe flu disease. And our next slide. So finally, this is our COVID-19 and flu mortality. And we saw a decreasing number of deaths from COVID-19 since 2021 when we look at the trends through to the 24-25 season, in which there were 98 total. And then on the graph to the right of that, we see that the flu deaths over that same time, we actually saw an increase between the 23-24 and the 24-25 season, reaching a peak of 60 in our past 24-25 season for flu deaths. And I'll turn it back to you, Dr. Fiscus.
All right, thanks so much. So let's talk a little bit about the recommendations for all of these vaccines for this year. Next, please. So recommendations for influenza vaccine really haven't changed. It's still 6 months and over. Everyone is recommended to receive a vaccine. And for children who've never received a vaccine in the season, who are under the age of 9, they need 2 doses a month apart, which means it's really important to vaccinate them as soon as possible. September and October are really considered the best times to get vaccinated, remembering that it takes about 2 weeks for those vaccines to really provide their optimal protection. There was a recommendation that was made by the Advisory Committee on Immunization Practices earlier this year to only provide flu vaccines that are thimerosal free. That means that multi-dose vials, which are the only vaccines that contain thimerosal, are no longer available through the Vaccines for Children program. Only a few percent of the flu vaccines given across the United States were given with multi-dose vials, but they were used in large-scale immunization events. And they were used by some of our island territories that really have to transport vaccines a long way. So you shouldn't see much of a disruption where you are, but it has had some impact on some of our jurisdictions. Next, please. And then just a reminder that egg allergy is no longer a concern. So we still see this popping up on consent forms asking whether or not people have egg allergy. They have said now for several seasons that we don't need to worry, even if someone has a history of anaphylaxis with egg allergy. The risk of that with flu vaccines, even those made in chicken eggs, is extraordinarily small. Anyone can have an adverse event to a vaccine, and so people who get vaccinated should be vaccinated in a place where someone can be there to respond to an emergency like that, but you don't have to take extra precautions for people with a history of egg allergy. Next, please. We pediatricians like to say flu before boo. Halloween is this Friday, so we really encourage people to get vaccinated before the end of the month. CDC doesn't recommend any particular formulation of vaccines for anyone under the age of 65. And flu mist is available for people who are ages 2 to 49. Over 65, they really should be getting either one of the high-dose antigen vaccines or an adjuvanted vaccines. I have those listed here. just because they tend to have a little weaker response to a standard flu vaccine. But if those higher dose or adjuvanted vaccines are not available, then a regular vaccine should be given to that population. Next, please. For COVID vaccine recommendations, as you likely know, things have been a little bit complicated lately. So just to kind of go through the chronology of the recommendations, back in May, there was the X announcement by the secretary and others from HHS saying that they were no longer going to recommend COVID vaccines for healthy children or pregnant people. This was followed by FDA revoking the emergency use authorization for all COVID vaccines in August. Next, please. But then they changed the approval language for the Moderna Spikevax from approved for use in individuals 6 months and older to approved for people who are 65 and older, and those 6 months to 64, those who have at least one underlying condition that puts them at higher risk. So that's the FDA label for the Moderna vaccine. Next, please. Then in September, the Advisory Committee on Immunization Practices met, and they gave the following recommendation that COVID vaccines should be used in individuals 65 and older based on individual-based decision-making, which can also be thought of as shared clinical decision-making. And then for individuals 6 months to 64, that they would also have vaccination based on individual-based decision-making or shared clinical decision-making, with an emphasis on people who have pre-existing conditions that put them at higher risk, having a greater benefit to the vaccine than people who do not have those kinds of pre-existing conditions. Next, please. So the final CDC recommendation that came out on October 6th was for 6 months to 18 years based on individual decision-making or shared clinical decision-making, and additional doses for those people who are moderately or severely immunocompromised, also based on shared clinical decision-making. And then that prompted the AAP and others to come out with their own recommendations. So AAP basically aligns with the CDC recommendations, except to say that they consider children under the age of 2 to be at high risk just by the fact that they're under the age of 2. So they recommend that children under the age of 2 or 6 months to 23 months be vaccinated with a COVID vaccine, that individuals who are moderately to severely immunocompromised receive vaccination, and that if a parent wants to vaccinate their child, that they should be permitted to vaccinate their child. Then we have seen some collaboratives of states come together. So the Northeast Public Health Collaborative that Rhode Island belongs to has put out their own recommendations that basically model what AAP has said. I call these the should, may recommendations. So children 6 months to 23 months should be vaccinated. Children and adolescents with high risk complications or at high risk for complications should be vaccinated, and anyone else who wants to be vaccinated may be vaccinated. Those might be some of the clearest recommendations that we've seen come out. Next, please. And then for adults, CDC recommends that 18 years and older be vaccinated, again, based on individual-based decision-making. Vaccination during pregnancy based on shared clinical decision-making. So note that even though there was the announcement on X that they weren't going to recommend for pregnant people, you can immunize pregnant people under shared clinical decision-making, and that there should be a consideration for additional doses for adults who are immunocompromised. Next, please. Those recommendations prompted ACOG to come out with their own recommendation that is people who are pregnant should be vaccinated. They can be vaccinated at any point during pregnancy or in the postpartum period, or if they're lactating. And then the American Academy of Family Physicians came out with the mashup of AAP and ACOG recommendations to say that yes, vaccinate children under the age of 2. Yes, vaccinate pregnant people, vaccinate people who are at high risk for complications, and anybody else who wants a vaccine should get vaccinated too. So this is the litany of recommendations that we've seen. Again, the Northeast Public Health Collaborative with their should be vaccinated if you are at high risk. You should be vaccinated if you are 65 or older, and you may be vaccinated if you are in another population. And then if you're pregnant or recently pregnant or lactating that you should be vaccinated. Next, please. So with the removal of the emergency use authorization and the approval, the full FDA approval of the Moderna vaccines, we lost the FDA approval for COVID vaccines for young children. So the only vaccine available for children under the age of 2 now is the Moderna vaccine. This is the red label vaccine. And it's a little bit tricky when you're vaccinating a child under the age of 2 because it depends on whether or not they've ever completed a primary series of COVID vaccines. So those babies under the age of 1 likely will never have completed a series of COVID vaccines. They need 2 doses of the Moderna vaccine. But if in the past they have received a dose of Pfizer vaccine, depending on how many doses of Pfizer vaccine, influences how many doses of Moderna vaccine you give. So the easiest thing to do is go to the AAP's quick dose reference guide. I've put that link here. You can just Google AAP COVID dosing reference guide, and they have it all laid out very clearly. I suggest that you print that off, maybe laminate it to have it in your office or in your clinic, so that you know exactly how many doses these young children are to get. Next, please. For older children, they just need 1 dose. If they just received last year's dose recently, there should be at least 8 weeks between last year's dose and this year's dose. For children under the or ages 4 and below, again, it's just the Moderna vaccine that's available. In some ways, that makes that easier for people. For children who are 5 and older, we do have approved Pfizer vaccine and the Moderna Spikevax, so you can choose between those 2. Again, they only need 1 dose and 8 weeks of separation if they've just recently received one from the prior formulations. And then for individuals who are 12 and older, you have a multitude of options now. You have Moderna Spikevax, which is the older Spikevax. You have the Moderna mNEX Spike, which is a new generation Moderna vaccine that was not previously available commercially. So this is the first year for that one. You still have the Pfizer vaccine and you have the Novavax vaccine. All of these now have full FDA approval. If they've never been vaccinated, they should have 1 dose. If they were vaccinated previously, you just need to make sure that you've got space of at least 8 weeks between those vaccines. It does say that you need to wait at least 12 weeks if they've had Moderna mNEX Spike previously, but they didn't actually manufacture and make that vaccine available last year. So you really shouldn't run into that anywhere. And again, the easiest place to look is that AAP quick reference guide. Moving on to RSV immunization recommendations, the CDC recommends that all babies be protected against RSV disease through either maternal vaccination during pregnancy or through the administration of a long-acting RSV monoclonal antibody that is given as close to birth as possible. And then adults ages 75 and older should receive 1 RSV vaccine, and people who are at high risk for severe RSV disease who are between the ages of 50 and 74 should also receive 1 dose of RSV vaccine. This is not an every season vaccine. This is just a 1 dose, 1-time vaccine as of right now. Next, please. And then in pregnancy, it is only the Pfizer Abrysvo vaccine that can be used in pregnancy. We do sometimes see errors where the other vaccine is used, but it has to be Pfizer Abrysvo between 32 and 36 weeks and between September 1st and January 31st for most states and territories. There's some variation of that in places like Hawaii or Alaska where they might see RSV all year. There is no recommendation to revaccinate with subsequent pregnancies as we do with Tdap right now. So it's just 1 RSV vaccine during 1 pregnancy, and that's all. Babies who are born during the season between October 1 and the end of March to mothers who did not get vaccinated should receive 1 dose of either the Sanofi Beyfortus or nirsevimab immunization, or now the Merck influenza or clesrovimab immunization product. Usually it's recommended that that be done within a week, and the priority should be to give that baby that dose before they leave the hospitalization after birth to just make sure that we're not putting them at risk. And then infants who are at high risk, like those with uh, cystic fibrosis or other severe conditions, bronchopulmonary dysplasia from severe prematurity, that are between the ages of 8 to 19 months and entering their second season of RSV should receive a dose of the nirsevimab product. The Merck product is not approved for the second season, and it doesn't matter if the mother was immunized or not during pregnancy for babies who are in the second season. So second season, high risk, 8 to 19 months, they need a second dose in that season of just the Sanofi Beyfortus nirsevimab product. Next, please. Oh, and then older adults now have three options: the Pfizer Abrysvo vaccine, the GSK Arexvy vaccine, or the Moderna now has an mRNA-based mRESVIA vaccine. Again, just one dose, one time for adults. Next, please. And I'm going to turn it back over to Dr. Ojugbele to cover any changes that might be there in Rhode Island.
Thank you, Dr. Fiscus. Okay, back to Rhode Island. So this graphic shows us the total
We
percent.
lost your audio just a little bit. It just got
See.
real faint. There you go. You're fine.
Okay, great. Thank you, Dr. Fiscus. So this graph is showing us the total percent of Rhode Islanders vaccinated for the 24-25 season, with that dark blue line being flu and the lighter blue line being COVID-19. So most Rhode Islanders, as indicated here, are getting their vaccines around that October time, which, as Dr. Fiscus mentioned, is that ideal timing. So we can see here that for the flu line, which is that top line, we were down slightly from the previous year. We were 35.6%. And in the 24-25 season, flu came in at 34.3% of Rhode Islanders vaccinated. And for COVID, we were also, again, slightly down from the prior year. We were at 17.4 and then coming in at 15.2 for the 24-25 season. Next slide. And here, this is showing us the recommendations that Dr. Fiscus went over. So these really have not changed for the state of Rhode Island. And I'll mention just a couple things. So for influenza, as Dr. Fiscus mentioned, thimerosal is a component of multi-dose flu vaccines, and all influenza vaccine injectable products through Rhode Island's state-supplied vaccine or SSV program are single dose. And that is also true for our private purchase vaccines, which are at our CVS and Walgreens in the state. So the CDC recommendation to preferentially administer a flu vaccine without thimerosal really had no practical implications for our state. We did see that the scientific and medical consensus continued to be that thimerosal did not pose a public health risk. And as Dr. Fiscus mentioned, an overwhelming majority of flu shots in the nation for the past year were thimerosal free or significantly reduced. And then just briefly, in terms of RSV, so we can be very proud in the state of Rhode Island that 72% of infants in Rhode Island for the 24-25 season were protected against RSV, either through maternal vaccination, which came in at 28%, or with immunization with nirsevimab at 44%. And that total came in higher than the national average, which was about 66%. And next slide. Thank you. So just a quick note on flu mist in our state. So in September of 2024, for the self and caregiver administered flu mist, that was approved by the FDA for that type of administration. And the 25-26 season is the first year of availability. So this is available in about 34 US states. However, it is not available for this season in Rhode Island. And next slide. So Dr. Fiscus went over this wonderfully, so I won't belabor the point. But in the state of Rhode Island, we do follow the AAP, AAFP, and ACOG guidance. And Rhode Island is a part of the Northeast Public Health Collaborative, and those guidelines for COVID-19 vaccine are consistent with those societies. And this graphic is just showing us the timing of administration for our fall respiratory virus vaccines. And, really just kind of taking a look at those faded lines, which, really show us that for the individual patient, we are taking into consideration risk factors, timing, et cetera, for vaccination at other times of the year for COVID flu, as well as for older adult RSV, again, based on that specific patient profile. And next slide. So in reviewing what Rhode Island has done in terms of protecting access to COVID-19 vaccine in brief, given all that was happening at the federal level. So in September of 2025, the Rhode Island Office of the Health Insurance Commissioner issued a bulletin requiring insurance coverage of COVID-19 vaccine for patients 6 months of age and older. And you can review that bulletin in the chat. The Rhode Island Department of Health issued a standing order that empowered pharmacists to administer the 25-26 COVID-19 vaccine in our state to patients 3 years of age and older, given the challenges with the new FDA labeling and what that posed for our pharmacists in the state. And finally, our Rhode Island general law had been amended to allow pharmacists to administer flu and COVID vaccines to children down to 3 years of age. And then just highlighting our specific immunization regulations in the state that speak to the fall respiratory vaccines. We do have regulations in place for childcare as well as for healthcare facilities, and that information is available on our website as well.
All right, thank you. So before we get to Q&A, let's go over a few messaging strategies. So, the thing to remember most is that people who have questions about vaccines have questions and concerns because they're afraid of doing something that's going to harm themselves or harm their child. And so coming at that from a place of understanding what that individual is ultimately concerned about is really important and paves the way towards our having better conversations. So sometimes asking permission to have a discussion is an easy way to kind of de-escalate emotions that might be in the room by saying, would it be okay if I ask you a couple questions about what you're concerned about? And even though, we as clinicians tend to assume that people come to us for our guidance and our expertise, taking a moment to ask if it's okay to enter into that conversation can really go a long way towards helping to foster some communication in that space. Next, please. Also, just expressing empathy. There are so many things out there that are scary. There's the claims about loss of fertility. There's claims about sudden infant death syndrome. There's all kinds of things. And so expressing some empathy and saying, I understand how hearing things like that could sound really scary. Would it be okay if I shared with you what I know about some of those claims? And again, trying to take some of the emotion and de-escalate the emotion that's in the room at the time. And then finally, reminding people that we're all in the same team. We as clinicians want what's best for you or what's best for your child, and would not make recommendations that we thought would harm them in any way, just as you want to make sure that you make informed decisions to the benefit of yourself or your child's health. Next, please. There has also been some work done by AAP in talking about immunizations and what they do as something like downloading antivirus software for your computer to help protect your computer against viruses that might be there to harm them, or using literacy as a metaphor, like teaching your immune system is like teaching someone how to read so that they understand words and can recognize those words in the future. If we teach our immune system to recognize what some of these bacteria and viral pathogens look like, that we can teach them to recognize them more quickly and then destroy them to help the body. Next, please. But I wanted to share this resource with you, which is a little known resource. This was done in a pilot that was funded by the National Foundation for Infectious Diseases and a company called Frame. And it's a dashboard that is available to you at no cost. It has just become public. And it actually provides hyper-local data around attitudes towards vaccination. Right now, this is just for the respiratory viruses. So it's flu, RSV, COVID, and also pneumococcal. And also how to message to certain communities based on responses that were given during surveys. So this was a national survey. It was just done this past January, so it's fairly recent. And I'm just going to take you through some screenshots of what this looks like for Rhode Island. So you can go into this and click on Rhode Island, and you can see based on the color gradation there. I'm looking, go back, please. I'm looking specifically at flu here. And you can see in Rhode Island that that lower part of the state is actually quite willing to get vaccinated against influenza. The upper part of the state, not as much, and to the east, somewhere in the middle. But you can do this for any of the respiratory viruses and see what kind of the general attitude is towards getting vaccinated. Next, please. And then we can go down another step. So I went into the county. So this is for Providence. And you can see by the dots there that there is this mix of willingness to get vaccinated. Again, I'm still looking at flu here. And you can see that, maybe in the northern part of the county, northwestern part, maybe a little bit more likely to get vaccinated. Lower southeastern part of the county might be a little more likely to get vaccinated. And then we can actually go into a zip code and go to the next slide. So I selected a zip code in Providence just randomly. And what this tells you is that in this county, about 50% of the adults in this zip code in Providence are interested in getting vaccinated against influenza. And it will tell you too some of the demographics of that area. So, it's mostly English, it's largely white, mostly some college or higher degree. It shows you the age demographic. And then it goes on to show you some other useful information, if you'll go to the next, on, for example, what the concerns are in this particular zip code in Providence County. So they're concerned that they're going to have to schedule multiple appointments to get their vaccines. So this might be an opportunity to talk about co-administration of vaccines, and that we can give RSV and flu or flu and COVID together. They're also not sure about eligibility for vaccines, which is, given all of the recommendations that I just read, that's a valid concern that maybe there needs to be some messaging in this area about that. They also talk about their concerns that the vaccines may cause the disease. This is, again, specific to flu, that they don't know if there's going to be side effects that they should be concerned about. And then it goes into some beliefs and worries and what their medical care status is. And then on the next slide, this is one more dashboard. So this shows you what their viewpoints are and who they listen to. So they like to listen to pharmacists and their doctors and also nurses, and less so social media, which is helpful. And then it tells you where they tend to get vaccinated. So we tend to be vaccinating against RSV and pneumococcal in a physician's office, but getting flu and COVID in a pharmacy. And then where their most common sources of medical information are, which here in this zip code, it's friends and family more so than providers. So maybe there's an opportunity to help providers message more clearly in this particular zip code in Providence. Next, please. And then it also tells you where they get their information. So if you wanted to target this particular zip code in Providence County, with medical information that they're looking at Facebook Messenger and Instagram and Facebook and CNN and Netflix. They're not listening to Pandora or looking at Reddit or reading the New York Times. And so for those of us in public health who are working on very slim margins for resources, it helps you zone in on where you might be able to get the best bang for your buck to message to a community that is willing to get vaccinated, who is receiving messaging through a particular type of platform, and what types of messages might best resonate with that community. Next, please. And then finally, they just give you kind of a summary of the whole area. And you can see in this particular county, they had surveyed 134 people within this zip code to come up with these data. So I encourage you to go to that. If you don't copy down the link, just search for NFID dashboard. It should come right up in Google, and go in there and play around with your community and see what you might be able to learn on how best to target your resources. Next, please. Back to Dr. Ojugbele.
Thank you, Dr. Fiscus. So I just wanted to share that we have some great communications materials that are available for download, and they can be used in offices, clinics, schools, anywhere the public can view this information on vaccinations. So the guide to vaccines is throughout the lifespan. And then we also have specific communications about RSV and fall winter vaccines as well. So these are wonderful resources that, again, are free for download and things that I have used in my clinical setting as well. Next slide. Thank you. And then finally, from October through February, the Rhode Island Department of Health is running a campaign to promote seasonal vaccinations against flu, COVID, and RSV. And this campaign specifically addresses vaccine fatigue sentiments. And it also reinforces the vaccine benefits in terms of protecting against severe illness. So those are the top line messages that this campaign is focusing on. And we've placed these ads in bus exteriors, social media, digital networks, streaming audio, as well as senior centers and housing facilities. And our social media messaging is the same. It is in English as well as in Spanish. And also we have our fall school located vaccination clinics, which are being held through November 20th. And these are not just for students of those schools. The evening clinics are open to the community. And if you go to schoolflu.com, you can find one near you.
And I'll just jump in with this list of the links for the resources. So you'll see that when you get the recording and when you get the slide deck. And then AIM also has some great flu resources, one called Connecting the Dots, which is a one-pager with all kinds of links to resources for different populations and uses. We also have a flyer that we co-authored with immunize.org that's specific to flu and the need for flu vaccination. Social media templates, other webinars that we've hosted. So lots of information there at AIM's flu resource page. Next, please. So let's get to some questions. Again, if you want to put questions into the Q&A box, we'll be happy to address those. I just wanted to start with Dr. Ojugbele. How is Rhode Island dealing with the messaging differences across, what you're hearing from the federal government versus what you're hearing from Rhode Island or AAP? How can we best get the right message out to the people?
Thank you, Dr. Fiscus. I think Rhode Island really benefits from being a small but mighty state in that, we really are able to communicate with one another, whether that's within state government, and with our clinicians who are, practicing direct care on the ground in terms of all delivering the same message. And that is based on science and following the recommendations of our trusted academic societies. We also benefit by being part of the Northeast Collaborative. And for COVID-19 specifically, our governor from the highest levels in our state has really been very vocal in terms of protecting Rhode Islanders' access to vaccination through some of those activities, such as ensuring that, our insurers continued to maintain coverage for COVID-19 vaccination, as well as the standing order that allowed pharmacists to be able to vaccinate despite the FDA guidelines. So I think we really, benefit from having a long-standing history of supporting vaccination and continuing that ethos in this state.
That's great. And I love the small state, big deal tagline. I think that's really great. Y'all have some terrific messaging coming out of Rhode Island around all of that. We do have a question that I can address here. So someone in the audience was asking about RSV vaccine and Guillain-Barré syndrome, or GBS. So as we see with influenza vaccine, there is a small increase in the chance of developing Guillain-Barré syndrome when you receive an RSV vaccine. It amounts to about 1 in a million administered doses, so it's incredibly small risk. But if you're that 1 in a million person, then your chance was 100%. So that's it's not to be taken lightly, and people may have concerns about this. They may have heard about it, but again, the chance of that happening is about 1 in a million administered doses. So it's very, very small. As there is more data that is collected around RSV immunizations, there may be some clarity one way or the other. Sometimes signals disappear, sometimes signals get larger, but they're continuing to monitor those cases of GBS at this point. So I will encourage you to go ahead and put questions in the Q&A if you have other questions. In the meantime, let's talk a little bit more about the RSV immunoglobulins that are being delivered in the hospitals in Rhode Island. So you mentioned that your infant coverage, I think you said, was around 71% or so, which is extraordinary. I mean, Rhode Island has led a lot of immunization stats across the United States. Rhode Island always tends to rise to the top in a little bit of a rivalry with Vermont, I think. You guys tend to be neck and neck, but can you talk a little bit more about how the hospitals have been able to come together to help to get those babies protected?
Yeah, thank you, Dr. Fiscus. So all of our birthing hospitals are enrolled in our state supplied vaccine program. And, with that, they were all really excited about RSV availability, as were we. And all of our birthing hospitals actually have a collaborative in which, they talk. We have 5 birthing hospitals in the state. And again, that small state really allows us to all be in a meeting together to talk about timing of access and to talk about availability. And during that first season, when we were dealing with shortages, it was incredible to see the birthing hospitals really communicating with each other, communicating with practices to make sure that children got access to what they needed.
That collaborative that they have sounds amazing. So, we have some states that have dozens of birthing hospitals, and they are always very interested in hearing how others have made it work. Rhode Island is special in that you don't have to worry about the reimbursement issues and payment issues through insurance like a lot of states do. There are about 14 states in the country that have a model that's similar to Rhode Island, where all of the vaccines are provided by the state or the VFC program. And so you don't have to worry about those negotiations so much, or worry about physicians being unwilling to carry vaccines because of the cost of them. So Rhode Island is very, very special in that way, and I do think it is in an enviable position by a lot of other states when we talk about other states trying to put these things in place, and then we have Rhode Island, and everybody's like, oh yeah, Rhode Island doesn't have to worry about any of this because of their universal purchase programs. That's really tremendous. Well, I'm not seeing any other questions coming from the audience right now, so I think we will go ahead and close. Just a couple of things from me. Keep an eye out for the next Shot of Knowledge webinar, which will be in January on immunizing through motivational interviewing. So how can we talk to patients and families about immunizing in a way that helps them understand how it impacts them specifically and the things that they care about. So stay tuned for the date and more information on that to come. And I would just like to very much thank Rhode Island Department of Health, and especially Dr. Ojugbele, for coming on today and giving us the Rhode Island perspective in all of this. And I hope that you all will go out and do everything you can to help protect Rhode Islanders through this fall season by getting them vaccinated. Thanks all very much.